Good morning, good afternoon. This is Mike Toso. I'm a program officer with the Johns Hopkins Center for Communication Programs. This is the 7th in our series of Malaria Social Behavior Change evidence-based discussions. Before we begin, I'd like to introduce our moderator, Bridget Higginbotham. Bridget is a malaria advisor for the U.S. President's Malaria Initiative. As a member of the Social Behavior Change team, she provides support to PMI programs in Niger and Guinea. Bridget is going to start us off today with a few words about how this activity fits within PMI's global strategy. Welcome, Bridget.
Thank you, Mike, and good day, everyone. The U.S. President's Malaria Initiative is supporting this activity, and I just wanted to say a word or two about how it fits into our strategy to support high-quality social and behavior change. PMI prioritizes activities that improve countries' capacity to collect and use information. While this often means country-level data collection, it should, in a broad sense, also mean taking data and lessons learned in other countries, and when appropriate, using it to inform other countries' needs. We are also very interested in building the capacity and health systems of countries we work with. From our perspective, regular discussion about rigorous malaria SBC evidence builds and maintains capacity among the malaria community. We hope this activity meets your needs.
Thanks, Bridget. Slide. We are recording today's discussion, and you'll receive a copy of the slides and the webinar recording. Microphones will be muted during the introduction and presentation, but we welcome questions. Please write your questions in the chat at any time, and we'll begin our discussion by answering them each in turn once the presentation is finished. Slide. These discussions are structured like research papers. If you're following along in the discussion guide that we sent around before the presentation, the blue slides will indicate which section addresses specific questions in the guide. Slide. In each of these discussions, we pull an article from the Malaria SBC evidence database. This is an online searchable database of malaria SBC evidence, which includes both peer-reviewed articles and gray literature. Please take time to explore it when you have a chance. In addition to learning about Amanda Chung's research, we hope today's discussion sheds lights on tips for reading and interpreting malaria SBC research for your own work. Slide. I'd like to introduce our presenter, Amanda Chung. Amanda Chung is the VMMC Sustainability Project Director at UCSF's Institute for Global Health Sciences. She leads the leadership and program management work for the Malaria Elimination Initiative. She has 15 years of global experience in the areas of program management and monitoring and evaluation for HIV, eye health, and malaria. She's also worked for public health departments and a community health center in the United States. Amanda is an MPH from the University of Washington and an AB from Princeton University. She is currently a doctorate PH candidate at University at UC Berkeley. I'd also like to introduce colleagues and co-authors from the Zimbabwe article who are part of this intervention and have generously agreed to join us for this discussion. Precious Chapati has 20 years experience in community and cooperative communications at local, regional, and international levels. Trained as a languages teacher, marketer, and radio television producer, she established the public relations departments for companies in manufacturing, tourism, agriculture, mining, and finance sectors. She launched Women's Magazine, focusing on women as role models in future generations. She has extensive experience as a consultant in health and other sectors and works as a facilitator with UCSF. Dr. Rudo Chikadoze is a medical doctor registered with the Health Professional Councils of Zimbabwe. She has a master's degree in public health, and she has extensive experience as a clinician and manager. Rudo has worked as a government medical officer, locum doctor at PSI, maternal and child health officer at provincial levels, and currently serves as the provincial medical doctor. Rudo is a graduate of UWE Bristol Business School, Change Leadership Postdoctorate Certification Program, and serves as a facilitator for UCSF. She is also a guest lecturer at the University of Zimbabwe in the MPH program. Dr. Joseph Murungu is the Africa Regional Lead at UCSF's Health Qual. He is a medical doctor with a postgraduate degree in public health and a fellow of the International Society for Quality in Healthcare. Joseph is a senior technical advisor for Pangea. Prior to joining Pangea, Joseph worked at different levels of the health delivery system in Zimbabwe, including coordination of the National HIV Care and Treatment Program. Joseph has a passion for strengthening health systems towards provision of quality, patient-centered healthcare. And finally, we have Dr. McDonald Hove, who is a district manager for the Ministry of Health and Child Care as one of our Change Leadership graduates and UCSF facilitators. He is now Provincial Technical Officer for OPHID under the USAID-funded TASK program. Slide. A recurring theme in this evidence discussion series is a focus on interventions designed to influence multiple audiences and structures within the socio-ecological model. Today's discussion will be unique as we have selected an intervention that set out to influence behaviors of district-level health system personnel and not communities and community-level behaviors such as ITN use, ANC attendance, or prompt care seeking for fever. The choice of this topic is deliberate and timely for countries that have begun to grapple with the issues specific to low malaria transmission. It will become increasingly important to learn how to build capacity at subnational levels as subnational health system personnel work to address very site-specific malaria issues and behaviors. The article we will discuss today describes the kind of behaviors that can be influenced at the societal structural level, behaviors that will make community-level SBC interventions more effective in low transmission contexts. I'll now pass the floor to today's presenter, Amanda Chung, who will take us through her research. Thanks again for joining us today, Amanda.
Thank you so much for inviting me to do this talk, Mike. I'm speaking on behalf of my co-authors and myself, in that we are very honored. First of all, I'd like to recognize my collaborators who were really instrumental in the design and execution of this work. The project would not have been possible without my Zimbabwean and South African colleagues, as they are the ones who worked most closely with the Malaria Program, leading our convenings and facilitating the change management process. I'd also like to highlight the involvement of 3 colleagues in the UK, Professors Peter Case, Jonathan Gosling, and Rolly Gosling, who are experts in organization development, leadership development, and malaria elimination. Peter and Jonathan are the main architects of this approach. So, sorry, could you go back one slide? Thank you. Okay. So when we look at this work with a socio-ecological lens, we really need to recognize the importance of having an enabling environment at the societal or policy level. So in this case, it really takes the form of having this National Malaria Strategic Plan, which is renewed every 5 years, as well as the fact that malaria is an important part of the national health strategy. Although we attempted to influence many different levels, our main focus is really at the organizational level, while also including the community, interpersonal, and individual. So looking at the community level, we focus on involving village health workers, political and traditional leaders, NGOs, and CBOs. And then at the organizational level, we focused on involving all different levels of the NMCP. So from the national all the way down to the health facility level. At the interpersonal level, we really focused on district health team building and improving communication and coordination. And then at the individual level, we focused on building skills in problem solving, active listening, meeting facilitation, and program planning. And then these other 2 activities around supportive supervision visits and on-the-job training were really ideas that came from the task teams themselves. And I will talk a little bit more about the task teams in future slides. Next. So I'm going to begin with a brief description of what we set out to do. And this is where we're going to discuss the situation and objectives of the work. Next. So in order to better understand the foundation of our work, it's really important to know that Zimbabwe conducted a review of malaria elimination progress and challenges using the WHO's Malaria Program Review Framework. This review found that subnational malaria elimination was indeed possible, but that it was really contingent upon system strengthening at the provincial and district levels. This paper really kind of set the stage for our intervention, ensuring that there was political will that was supportive of our work. So we had buy-in at the national, provincial, and district levels within the malaria program. Another thing to note is that Dr. Rudo Chikadzore, who is a co-author of this study, is one of our Change Leadership graduates and now an organization development facilitator for us. Next. Work is also in alignment with global guidance and recommendations on what it will take to achieve malaria eradication. So the Lancet Commission on Malaria Eradication stated, effective management and implementation of malaria programs are the most important requirements for national and regional elimination and eventual global eradication. There is actually mention of our work in Zimbabwe in section 3 of the report under management and operations. And also Drs. Rolly Gosling and Jim Tulloch, who are both co-authors of the report, were involved in the piloting of our interventions, both in Zimbabwe and in Eswatini. Lastly, this work was based upon the findings and recommendations of a background paper on malaria program management that was written by my US and UK-based colleagues. Next. So the goals of our project were to work with district level malaria teams to number 1, increase productivity, coverage, and quality of operations. Number 2, to develop management capacity at the subnational level. Number 3, to empower frontline workers to take ownership, solve problems, and act on decisions. And number 4, to optimize limited resources while integrating for efficiency with other programs. Next. So our audience was really the district health management team, and that was comprised of facility and community level health workers. But as we progressed in our work, we realized that we were missing some key stakeholders, that being community stakeholders. So we made sure to include them in the next iterations of our work. In terms of the behaviors that we were hoping to change or improve, these included teamwork and communication, understanding each other's perspectives, roles, and responsibilities, and identifying and solving problems. Next, please. So now I'm going to cover the methods, and this is where I'm going to describe the study design and overall analysis. So some of you may be familiar with this. This is the WHO's framework for action, and it's not actually a malaria-specific framework, but it rather applies to health system strengthening in general. It really provides a basis to support countries in scaling up health systems and services by addressing bottlenecks in a collaborative and coordinated way and driven by desired health outcomes. Countries can achieve sustainable system-wide effects. To be most effective, this process must be country-led and based on the priorities set out in national health plans. And we would actually argue that ideally these priorities are bottom-up, led by the frontline workers who are most familiar with the realities on the ground. Next, please. Our pilot program does not really fit a classic study design, as it was participatory action research with a mixed methods outcome evaluation. So change was measured within the pilot areas by collecting baseline, midline, and endline quantitative and qualitative data. However, due to data access and funding limitations, we were not able to collect comparative data in non-intervention districts. Next, please. So in order to better understand our project, you need to kind of know about 2 different disciplines, and those are organization development and quality improvement. So these are complementary and actually serve to strengthen each other when used in combination. So organization development emphasis is really on organizational effectiveness, performance, and problem solving, while quality improvement focuses on data-driven change interventions and learning networks. What we set out to do was really to recreate the system in the room. And by that, I mean replication of the malaria program within the meeting venue. So this really helped to try to break down silos between different levels and disciplines such as vector control, lab surveillance, and case management. This gave participants an opportunity to define and discuss their specific challenges, gain a better understanding of the roles and responsibilities of their coworkers, and crowdsource solutions to challenges. We also tried to enhance communication and coordination and facilitation of change using structured exercises to facilitate active listening, peer-led problem solving, and employed root cause analysis and prioritization tools and techniques. Next, please. So in the first year of our work, from 2016 to 2017, we piloted the work in 2 districts in Matabele Land South, Baitbridge, and Gowanda. Next. And then in the second year of work, we continued to work in Mat South, but then we also expanded to include all 7 districts in Matabeleland North, as well as 2 districts in Midlands Province. Next. So this study timeline just gives you an idea of where we were working and when. And really, we wanted to pilot initially in one province and then expand to ensure that our methods worked in other areas. We also really tried to keep sustainability at the forefront of our minds, training the NMCP as well as any NGO staff in process improvement and organization development methods in order to facilitate change with limited support from us, since we knew that we would eventually have to withdraw that support. So 3 of the 6 individuals who were selected for training actually completed a year-long postgraduate certification in change leadership through the Bristol Business School at the University of West of England. Next, please. Our intervention started off with an initial workshop for about 30 to 60 participants, and the table on the right, you can actually see the composition of those workshop participants. So there was representation from the health facility all the way up to the national level. During these workshops, people were broken up into small groups to analyze individual challenges and develop potential solutions. Then task teams are these cross-disciplinary and cross-hierarchical subset of workshop participants who come from different cadres and represent both district and provincial levels. Next. The task teams then each created a district level action plan, and then they met periodically to take service delivery challenges forward, selecting indicators to really monitor progress toward targets and to address new challenges and solutions. A follow-up workshop then reconvened the initial workshop participants to evaluate progress and define new priorities to be incorporated into provincial level planning, budgeting, and reporting for the following year. Next. So this figure is just showing the cyclical nature of our overall process, starting with that initial workshop up at the top, during which challenges are identified and prioritized by a large group. And then the task team takes over with the development of the action plan and selection of accompanying metrics to measure change. They're responsible for actually implementing the work plan, gathering data, and analyzing results. All the while, they are following a plan, do, study, act cycle, which comes from quality improvement and receiving continuous mentoring and coaching. And then, as I had mentioned, we also focus on training change leadership facilitators. So then this takes us back to the top of the circle again, which is when we had a follow-up workshop to reconvene the participants from the initial workshop. And this was the opportunity for the task teams to report back on progress and also to incorporate feedback into the plan for the next year. Next. So this process actually seems to very closely mirror that of the systematic and iterative SBCC planning process. Next. I'm now going to discuss the results of our intervention, and so the next few slides describe the outcomes and impact of our work. Next. So in terms of overall results, by the end of the 2 years, we had task teams that were operational in 3 provinces and 11 districts, and we had also trained 3 people in change leadership. So in terms of the challenges, these were selected by the districts. The task teams identified their own operational challenges, prioritized them, and then set about overcoming them by producing action plans. So the slides that follow are really the prioritized challenges that the districts chose to solve. You'll see that the priorities really differ by district, and despite the variety of these challenges, for the most part, improvement occurred. Also, there was really kind of success of this program because of how the different cadres work together to overcome their own specific challenges, finding human and financial resources that could be utilized at the local level, improving communications across the team, and learning more about each other's capabilities. Next. We used a participatory evaluation approach whereby each district selected the indicator by which they would measure change for each challenge. So you can see in this slide that 2 pilot districts in Mat South chose to focus on malaria register availability. And in Baitbridge, they actually did not see improvement due to a malaria outbreak. So they actually ran out of registers during this period, and they realized that they really needed to scale up printing of these registers during an outbreak. However, Gowanda was able to see improvement, and this was achieved by conducting an audit at health facilities and then also providing supportive supervision visits. During these visits, health workers were trained on the use of the malaria register, and really kind of the importance of filling this out in the first place was underscored. Next, please. So another challenge that this province selected was the supply of malaria drugs, and this was measured by the percentage of stockouts in health facilities within both districts. So you can see from baseline to midline, the percentage of stockouts of ECTs and Primaquine decreased, but then there was a maintenance of more of kind of a low level of stockouts between midline and endline. And this was accomplished by continuous monitoring of medicine stocks by the pharmacy manager. Next. This last result that I'm going to highlight from Mat South was the challenge of case investigation within 3 days, which the task teams chose to address through mobilizing additional human resources, implementing a tracker system, monitoring this metric during monthly meetings, and also providing weekly feedback to districts. So the overall baseline and midline data were an average across both districts, and then at endline, the data was disaggregated by each district. Next. Okay, this slide shows a couple of results from Matabeleland North, where the task team chose to focus on slide examination rates, which improved from 81% to 89%, as well as case investigation rates, which improved by 10%. So they accomplished this by identifying focal persons to follow up on surveillance issues, providing mentoring and supportive supervision on how to use the DIHS2 tracker, also regular on-site data verification and data cleaning, as well as the initiation of regular surveillance meetings, because these were only happening periodically. Next. So in Midlands, one of the challenges that these 2 districts chose to focus on was case management. So measuring the treatment of confirmed malaria cases with ACTs. And you can see that this improved in both districts and was accomplished by providing supportive supervision and community training. Next. So the costs per district really kind of decreased with an expansion of the work, with the average cost per district amounting to $26,000 by year 2, when we were working in the 3 provinces and 11 districts. Next. So now that we have reviewed the results, it's really important to ask, what does this all mean and how can this help me? So our next slides will explore programmatic implications and generalizability. So this project actually originated in Vietnam, where Professor Peter Case was working with the malaria program. And although the challenges and solutions mentioned in the paper are site-specific, the overall participatory and action-oriented organization development and quality improvement approach is applicable and replicable in other settings. In fact, we have packaged our approach into what we call the LEAD framework. LEAD stands for Leadership, Engagement, and Improved Accountability and Delivery of Services. And we have used this framework in other countries, including Eswatini and Namibia, as well as we are currently working with an HIV prevention program in Zimbabwe. Next. So in terms of the strengths of our work, we really placed focus on building soft skills such as communication and teamwork that often get little attention. The Lancet Commission on Malaria Eradication calls this the software rather than the hardware of malaria eradication, but acknowledges that really both are necessary to eradicate malaria. Participants reported an increase in motivation, morale, and accountability. And something to note is that challenges were really not prescribed by us. They were selected by the participants in that they were challenges that these participants faced in their day-to-day work. District level staff were really empowered to identify and solve problems, make decisions, and take actions. And they also changed the way they operated both structurally and functionally. We built skills and really tried to strengthen capacity at the subnational levels because we were trying to keep sustainability in mind. And we also offered the postgraduate certification in change leadership. Next. In terms of the limitations of our study, it was not possible to include non-intervention districts as part of this pilot. So the effectiveness of this approach when compared to Ministry of Health standard operating procedures is limited. Also, something to note is that this was not an RCT or an impact evaluation. So it is not possible to fully attribute our performance improvement to this intervention alone, partly because of the study design, but also due to the presence of external donors as well as partners in the areas where we were working. Next. Some lessons learned from our work include that key to success was the ownership and empowerment of district level leaders to identify and solve operational challenges within their control. Operational implementation is also often achieved only through inventive coordination across functions and levels, and personnel at all levels and in all functions need to understand the operational differences between strategies aimed at malaria control and elimination. Next. We also realized that at times we needed to develop new indicators to measure change over time. So for example, it was very difficult to measure the low use of insecticide treated nets and late treatment seeking at the community level. Another thing was that political will and national level participation is necessary for program success. We needed national representatives in the follow-up workshops to hear the results and also to hear about any unresolved challenges that might need additional resources, but also to ensure continuation of activities. Next. Hard to reach populations are extremely varied and require specific approaches that are sustained over several years and often depend on the quality of relationships between key individuals in those populations, as well as district level health personnel. So one example was IRS refusals, which were common in hard to reach populations. So a solution in one village might be leveraging relationships with a village leader, while in another village, it would be something completely different, like working with a school teacher or persuading the pastor of a church to support the IRS campaign. Next. In terms of implications for our work, this is an operational model for national malaria programs, and we are proposing this model where the district health team is at the center of operations. This model reimagines the roles, responsibilities, and relationships between national malaria programs, district level health units, and community platforms. Here, the community and district work together to identify operational challenges and implement solutions. The district feeds community level feedback to the national program, which in turn adjusts national policies and strategies in response to that feedback. Next. So the operational challenges for malaria elimination requires a shift in the way malaria programs work with communities, ideally from informing to empowering communities. This can be accomplished when community engagement is a participatory process, directly involving communities in decision-making, managing activities, and measuring results. This approach has the potential to improve program design and implementation, reaching populations with poor coverage and leading to efficiencies and sustainable results. Next. Next. Malaria elimination is really an end-to-end process. So generally, there are strong linkages between communities affected by malaria and their local leaders, as well as good coordination between national malaria programs and district level health units. However, there is a large operational gap between community structures and district level health service delivery. And this gap limits the impact of community health worker programs, village health communities, and malaria services. Next. So in order to fill this gap between the community and the district, the health system needs to focus on building formal linkages between decision-making bodies and the community. One possible solution for filling this gap is a participatory ODQI approach such as ours. Next. So in conclusion, for many health programs, implementation challenges occur at the periphery. Malaria programs can really greatly benefit from the local tailoring of solutions and engaging communities as partners in both planning and problem solving. The success of our intervention really came from the ownership of challenges. The individuals who participated were those most closely involved in malaria operations, and therefore they were most invested in the resolution of those problems. Malaria programs really need to go above and beyond, and they cannot just conduct business as usual if they want to eliminate malaria. It really requires a reorientation from a top-down to a bottom-up way of working. Lastly, change is possible when frontline workers are equipped with the skills and authority to not only make decisions, but also to take action. Thank you so much for your time and attention. My co-authors and I are now happy to address any questions that you may have. And I also hope that this is an opportunity for you to hear from my Zimbabwean colleagues. Next.
Thank you so much, Amanda. So we're going to start with some of the questions from the chat. Thank you so much, everyone. Please keep the questions coming as we start the discussion. We're going to start with Clive Schiff. Clive, if you want to unmute yourself, feel free to ask the question. If your microphone doesn't work, I'll pose the question for you.
Yeah. Good morning or good evening, and it's a great pleasure to see some of my Zimbabwean colleagues in the list, because that's where I did my own work, and in fact I was involved in the malaria program from about 1959 until 1980. So that's my home. I feel that listening to the current talk is very interesting, but malaria control itself requires adjustments to the scientific information as it comes in. And actually, I mentioned that just about a week ago in the Lancet, there was a paper stating that artemisinin resistance has been now definitively found in Rwanda. So we have it in Africa and we have to worry about it. So things change. And there is a very good infrastructure system in Zimbabwe, which was used when I was there. That is the National Institute of Medical Research. In those days, it was called the Blair Research Laboratory. So this is an infrastructure that can actually take information right down to the local level. We did that in the 1950s. We had people that were capable of going down to the community and explaining things to them. So I think that what you're doing is good, but I think that one has to focus a little bit on the on the changing signs, which we have to be aware of all the time. Over.
Thank you so much. And if I can just repeat the question very briefly and give Dr. Rosing a chance to speak for the program itself. It sounds like we're talking about oversight of malariologists to keep up the current science and what sort of oversight is going on currently. Dr. Gosling, can you unmute yourself?
Yes. Hi. Yes. Thank you for giving me the opportunity to speak. I was trying to unmute, but I wasn't allowed. But thank you. Yes. So, Clive, really well taken comments about how technical aspects of malaria are very important in malaria control and elimination. Absolutely agree with that. Where I would say our work in malaria elimination has really changed dependence of malaria control on technical information is understanding that at the point of delivery, there are a lot of barriers to implementation that are not technical, and in fact, they're operational. And this is what it's about. When you get to malaria elimination in particular, it is about reaching everybody who needs the interventions that we know work. And what we find out, and in a way, this is reflective of kind of malaria on the whole African continent at the moment, that we've kind of delivered the interventions to those people that are relatively easy to deliver interventions to, and they have been very, very effective. However, now we're stuck with how do we deliver interventions to people who are difficult to reach? And for that, you can't have a national policy. You can't have a technocrat in a capital city saying broad comments about things that are very, very local in nature. And I think, you know, we can talk to the colleagues who really put this into practice, and they can come up with lots of examples of where a central opinion on a technical issue wouldn't actually help the delivery of bed nets to a certain group of people that aren't accepting bed nets, or people who won't let indoor residual spraying personnel into their house because they think either they're the HIV team coming to test them, or they think I've got lots of contraband in my house, I don't want people coming in. You know, there's so many different reasons that those can only really be sorted out at a local level, and they are operational in nature. So this is really what this work is focusing at. It's saying we do have technical problems that we need technical people to solve, but we also have operational problems that are perhaps more essential and are currently missed in malaria programming. Over.
Thank you so much for the question and for the detailed response. We're going to jump next to Helen Hawking's question. And Helen, do you want to unmute yourself and ask a question if your microphone works? Otherwise, I can read it.
I had a couple of questions in my head. I think the question that I asked, I'm just trying to find it now.
I believe you're talking about district level staff empowerment.
Ah, yes, yes. How to influence, what actually was done to influence the behavior, the motivation of the district level staff.
Thank you so much. And we're going to try to unmute McDonald Hove. McDonald, are you there? Would you unmute yourself, and if you can respond if your microphone works? Oh, it looks like McDonald has dropped off. I'm going to jump next to Amanda.
Okay, sure. So in terms of empowering district level staff to make decisions and take action, I think it was really through these first, you know, at these initial workshops where individuals were broken down into small groups to talk about kind of the day-to-day challenges that they faced. And then they were grouped with about 4 other colleagues who could then listen to the challenge that they talked about, kind of examine that challenge in more detail, and kind of interrogate and better understand to then propose potential solutions to those challenges. So I think it was maybe that exercise that really kind of helped staff to understand that, you know, the challenges that they're facing are things that they could ask their colleagues to help them to address. And then just, I think the overall creation of those task team action plans was another vehicle to ensure that the individuals at the district level were really empowered to make decisions and take action. So I hope that helps to address your question, Helen.
Yes, thank you.
what you enjoyed with you. Thank you.
Thank you
Thank
so
you
much,
so much.
Brian. Sandra.
Go ahead, Helen. We're going to take another question really quickly. This is from Christy Billingsley, who is the PMI resident advisor in Zimbabwe, the United States President's Malaria Initiative. Christy, if your microphone works, would you like to pose your question?
Hi, can you hear me?
Yes, we can.
Okay, great. Actually, before I ask the question, I just wanted to share, in case some people aren't aware, that the NMCP just conducted a knowledge, attitudes, practices, and beliefs survey to try and get at what are the special needs of what they call special groups that the regular malaria interventions that we all know and love have trouble reaching. Some of these groups because of the way they live or the way they work, if they're migrant workers, if they are stream bank agriculturalists, and they have a sprayed home, but they don't actually live in that for 6 months of the year. So we haven't seen the results of that study yet, but it will be really exciting to see it. And I think, I don't know if anybody from the program is on, but I think they see their role as helping facilitate information and mapping of those groups so that lower levels, specifically the community, can work at that level. So I just wanted to point that out. And my question is, let me find it here. Oh, somebody already responded. What I wanted to know, if any of the teams looked at their role in reaching out to the existing community structures, specifically the health center committees, which exist in Zimbabwe, and the village health workers. And if they basically looked at what has their performance been in reaching out to them, and did they feel that was successful, and is that something that they wanted to improve upon? Thanks.
Thank you so much, Christy. And we're going to turn it over to our co-authors, the colleagues from Zimbabwe who are on the line. We'll start with Precious. Precious, if your microphone works, would you mind unmuting? And if Precious's microphone is not working, we will jump to Rudo. Rudo, are you with us? It looks like the microphones may not be working. We're going to jump to the next question, but if we have anyone from the country level who would like to reply in the text, we'll take those responses and I'll make sure to read them out. We're going to jump to our next question, and this comes from Bridget. Bridget, would you like to pose your question?
Yes, thanks, Mike. So I was wondering if the authors, if you had any, you could share more about how you went about maybe, or the team convinced the top to switch away from a top-down model to more of a bottom-up model. And along those lines, many of the attendees today might work within SBC or IEC units. So how would you recommend that they use the study to advocate for broader change in their country's malaria programs?
And we're going to go to Amanda first for the response in this one.
Yeah, thank you so much for that question, Bridget. I think really some evidence kind of from our paper is just that in kind of reviewing all of the various challenges that were incorporated into the action plans, you'll see that there's kind of a lot of granular detail because the people who were involved in developing these action plans were most kind of closely involved in kind of the implementation of various policies and procedures. And so I think just in reviewing those plans and seeing just the specificity and also kind of the nature of how the challenges were addressed with various solutions, that can be one way to help kind of convince people to switch to more of like a bottom-up way of planning. So I'm not sure if anyone else on my team would like to address that or add to what I've said already.
Thank you so much.
Hi, Amanda. Amanda, it's Peter Case.
Yeah, thank you.
Mike, is it okay if I just elaborate a little on this
Please
point?
go ahead. Thank you.
Thank you. So, yeah, great question, Bridget. I think it's critically important that one secures senior authorization of this kind of approach. So with this particular set of interventions, we were very careful to ensure that we approached the director of the NMCP and explained our motives and our plans, and indeed to get that endorsement at that level, and formally through obviously official letters and so forth, to ensure that that message got out to PMDs and others at district level, so that we created, if you like, the degrees of freedom to work using this lead methodology. And then what happened, I think, is once we had those degrees of freedom, we were able to run inception workshops and task teams. And what becomes apparent to participants is that their voice gets heard. We have structured techniques by which the relatively powerless in a system do actually get heard by people at more senior levels. And that becomes an incredibly revealing process for everyone concerned. You know, it's a surprise to those who are typically disenfranchised to discover that they are actually getting space to be heard. And it's a surprise to those in more senior positions of authority with particular kinds of medical knowledge and so on. And perhaps this would speak also to some of the points that Clive mentioned earlier. You know, that people with technical knowledge quite often get surprised by the expertise of people with local granular knowledge. And so this becomes a self-reinforcing process. It works. And then people get enthusiastic about it, and then you can move into building these cross-disciplinary, cross-hierarchical task teams to get into that granular detail and implement stuff. Does that help, Bridget? Does that answer your question, or was there something else that I missed there?
No, that's great. Thank you.
Thank you. Over.
Thank you so much. And I do see that Joseph Murungu is still on the line, and I want to make sure that we give as much opportunity for our Zimbabwe colleagues to respond as possible. Joseph, are you with you? Are you with us? And if you are, you can unmute yourself.
Thanks, Mike. Yes, I'm around.
All right, thank you. I'm just wondering, Joseph, if you would be able to answer Christy's question. And I believe Christy Billingsley was asking about whether or not local structures like community health workers and the structures that they work within, whether they were involved or could be involved with this process.
Yes, so we engaged community health workers, like village health workers. We were also working very closely with other community and traditional leaders. So you'd find that some of the task teams would include traditional chiefs. Some would also include the district administrators, now called district development coordinators, and some would include councillors. So we had good representation, not just from the community health workers, but the other critical cadres that were contributing to some of the decisions and activities that were being led by the task teams. Thank you.
Thank you so much, Joseph. We're going to jump to a question by Catherine Bertram. Catherine, if you don't mind unmuting yourself and pose your question.
Sure, thanks. And this has been so interesting, and I love the emphasis here on the operational pieces, which has been said over and over. Hasn't really been, I think, part of a focus area or conversations as much. And thanks so much for highlighting this. My question was around the information that was presented out on the increases in morale, motivation, and accountability. And I was just curious, because it's hard to measure those things. And I was curious how you were looking at measuring those and yeah, what method you used. Thanks.
Yeah, thanks for that. Yeah, that's a great question, and acknowledging, yes, that it is really difficult to measure those things. And ideally, we would be doing some sort of knowledge, attitude, practice survey that we had administered prior to the intervention and then post. But unfortunately, I don't think that we really necessarily thought through the design of that in great detail. And so we did actually collect data through qualitative means, through participant feedback forms that we administered after each workshop and task team meeting. So it was really just from kind of the comments in the free response sections of those feedback forms where we gathered this information.
Thank you so much, Amanda. And we're going to jump to another question from Bridget. We've got a question about how gender played. Bridget, do you want to pose your question?
Sure. It's perhaps not very specific and maybe not the most well articulated, but I'm just kind of curious how, whether gender was a consideration in the pilot or how you saw it at play. I think that something like this, kind of getting to my earlier question, there could be a lot of like power dynamics. And so just curious whether you all were looking at any gender considerations or you saw anything pop up in your work. Thanks.
Thanks for this question, Bridget. I will also attempt to answer this one. So I will say that I really wish that in the earlier pilots that we had been gender intentional about this work. I will say that I think we tried to ensure that there were females representation on all of the task teams at the workshops, and that when we solicited for participants to participate in the year-long certification in change leadership, that we ensured that there were at least some females who were selected and then trained. I think we've tried to be intentional about kind of elevating women to leadership positions kind of just within our own team. And I don't know, I think it's something though that we really need to pay more close attention to and be more intentional in the future. So thank you for that.
Thank you so much, Amanda. We've got another question here from James Fofana. James, do you want to unmute yourself?
Yes, thank you very much for giving me this opportunity, and thank you to the presenter for such a wonderful presentation. A lot of learning in there. But my specific question really relates to traditional healers, or herbalists. Given the intervention really talked about reaching out to the hard to reach, and the involvement of traditional authorities in the intervention piece. Traditional healers, to give you some context, especially within like Sierra Leone, play a really very key role in malaria prevention and control in our own context. I don't know for Zimbabwe, of course, where you find out that a lot of people trust them for malaria treatments, and so therefore will prefer to go to a herbalist to be treated for malaria than of going to a health facility, even if the health facility is very close and proximal to where they live for various reasons. So I was wondering with this study and intervention, whether amongst the traditional authorities you involved in the study and the intervention, whether you consider traditional herbalists and whether in fact traditional herbalists or healers are a problem in Zimbabwe for malaria care seeking. And if you do, did you observe any behavior change, things in terms of care seeking, things like referring people who reach them out for malaria treatment and refers them to a health facility to be treated instead of them applying whatever herbs that they think will cure malaria, which in our context often leads to a disastrous situation because they are not always right, and in most times they are not right. So I just wonder whether you could throw light on the involvement of those traditional authorities and traditional healers or herbalists in particular, and whether that lead to any behavior change on things like referrals for malaria care seeking. Thank you.
I'm going to open this up to any of the co-presenters or co-authors.
Hi, Michael, this is Joseph. Yeah,
ahead,
that's
Joseph.
a very interesting question. Yeah, so the issue of traditional healers and also spiritual healers continues to be a problem here in Zimbabwe, not just for malaria, but pretty much any other condition, including TB, HIV, and other chronic conditions. With malaria, we also picked it up when they conduct their audits that some of the complicated cases or even deaths were related to delays in coming to the health facility because the patients opted to go to a traditional or spiritual healer first. So with the malaria work, we didn't have any traditional healers as part of the task teams. But now we have learned, so with the current project, we actually have some religious leaders or prophets or pastors as part of the task teams, because we do realize the impact and the difference that they can make in terms of some of these interventions and responses. Thank you.
Thank you so much, Joseph. As we only have 2 minutes left and we have a few slides, I'd like to wrap up the discussion section of our presentation. Thank you so much for the participation, for your lively questions. And thank you, Amanda, and to the entire team in Zimbabwe for taking the time to share your research with us. Excellent presentation with fascinating results. I'd also like to thank Fortunate Manjaro, who joined us in the early part of the presentation. She is Zimbabwe's National Malaria Control Program SBC head, and she has been instrumental in both the SBC strategy that has been developed since this intervention, as well as the ongoing efforts for social behavior change. Before we wrap up the webinar, I want to remind everyone about the resources we mentioned earlier. The Malaria SBC Evidence Database is searchable by country, intervention, audience, and study design. The evidence database also contains links to infographics. As you can see here, we have infographics that show the impact of ITN use, service provider behaviors, malaria case management, SBC. There are also fact sheets that summarize the key findings from 3,600 peer-reviewed articles and 1,700 gray literature articles. The fact sheets are presented in 3 malaria technical areas: insecticide-treated net behaviors, case management, and service provider behaviors. In addition to the SBC Malaria Evidence Database, we'd also like to draw your attention to the LEAD framework described during today's presentation, as well as the Malaria SBC Strategy Development Guidance for countries with low transmission areas. This is a new tool that's been recently released by the RBM SBC working group, and we're very excited to say that Fortunate Manjaro from the MCP in Zimbabwe led part of that, the development of that guidance. And you can find the links to all 3 of these resources in the email that we send after this presentation with the recording of the webinar. With that, I'd like to thank you all so much for joining us. Please stick around until you see the post-webinar survey on top. This will help us make sure that future webinars are designed to meet your needs. Good day, good afternoon, good evening, everyone. Thanks.